I think my slides are clear to you. Everyone can see.
Yes.
Yes,
Okay,
it's okay.
thank you. So I hope you all got some time to study the bones of the lower limb. So again, we have gait 2. So our ILO for gait 2 is to know the muscles of the gluteal region and thigh. Means the muscles which act on hip joint and knee joint. Okay? Their details like attachment, innervation and function. So this is just for revision, the anterior view. Now all of you know everything about the anterior view, what important landmarks you can see. This is the posterior view. Also, we know everything about this. So because every attachment will be from these bones. Okay, so what are the point we have highlighted? All the muscles will be taking origin or insertion from these points. Great. So we have the muscles of the gluteal region. The gluteal region is the part where you are sitting, is the part where you take the intramuscular injection. Okay, so this is a very bulky part where we have many muscles. In this we have some bigger muscles, in which the biggest is the gluteus maximus. Okay, maximus means maximum. So this is the largest, even this is the thickest muscle of the body, gluteus maximus. Then you have another muscle which is medium in size, so you call gluteal medius. Then you have a smaller muscle of this group, gluteal minimus. Okay, then in gluteal region again you have one muscle which is not that big, but it is present and it is performing one of the important function, that is called as tensor fascia lata. Okay, its name is like fascia. Okay, tensor fascia lata. You will see the details. Then we have some short muscles. So when you remove these larger muscles, maximus, medius, you will see some small short muscles. These are piriformis, gemellus, two gemelli, gemellus superior, gemellus inferior. You can call gemellus or gemellus. It's both okay. Then we have obturator internus. Then we have quadratus femoris. So what is common about these short muscles? They all are the lateral rotators of the thigh. Okay. So here we have, first, if you remember, I told you that the outer or external surface of this, it is known as the gluteal surface. Okay, the gluteal surface on the ilium bone, if you all remember. So this green color is representing the gluteal surface, from where the
Doctor,
yes.
I'm sorry, but can you send us your slides because we don't have them?
Okay, so we know in the ilium we have two surfaces. If you know, the external or outer surface is called as gluteal surface, which gives origin to the gluteus, three gluteus muscles, medius, maximus and minimus. Then we have the gluteal tuberosity. If you remember, on the posterior surface there was a tuberosity called as gluteal tuberosity, which will provide insertion to the gluteus maximus. Then what about the medius and minimus? They will be inserted over the greater trochanter. Okay, so in this chart you can find the same thing what I told you. The gluteus maximus, it will be coming from outer surface of ilium, and as this is a larger muscle, so some fibers of this will come from sacrum, coccyx, sacrotuberous ligament also. Okay, medius and minimus, they will come from outer surface of ilium. Then what about the insertion? So as I have already told you, it will be inserted to gluteal tuberosity, and medius and minimus will be inserted to the greater trochanter of the femur. Okay. Then what is this iliotibial tract? Okay, some fibers of the gluteus maximus, it is inserted over the iliotibial tract. So let us find out what is iliotibial tract. So now you can see this is the thigh region. Okay, this is inguinal ligament, and here we have the deep fascia of the thigh. Deep fascia of the thigh, which is very thick, and it is called as fascia lata. Okay, so if I will ask you what is fascia lata, you should know that this is the deep fascia of thigh and it is very thick. Now we have one muscle which will keep this fascia tense. Why you need this fascia to be tense? Because the lower limb has one of the function for standing for the long time. So if you stand for the long time, you need all muscles to be tied together. So this fascia will act as the tire for all the thigh muscles. For this also you have one muscle which is called as tensor fascia lata. Okay. So what is fascia lata? It is a deep fascia. What is the tensor fascia lata? It is a small muscle which will keep your fascia tense, which will help you in standing position or extension. Now this tensor fascia lata, if you can see, there is again a white line which is coming from the iliac crest to tibia. This is called as iliotibial tract. Okay, this iliotibial tract is also a thickened fascia which will receive insertion of gluteus maximus. You can see the gluteus maximus and you can see the insertion of tensor fascia lata. Okay, so here again you can see this is iliotibial tract, okay, which is receiving some of the fibers of the gluteus maximus, and remaining fibers of the gluteus maximus, they are going to the gluteal tuberosity. Here you can see both the fibers of the gluteus maximus and it's both insertion. So now the tensor fascia lata is clear. It is a small muscle which will make the fascia lata tense, which will help in extension of the knee joint, which will help in standing. Its origin is from iliac crest and its insertion is over the iliotibial tract. Now what is the nerve for gluteal region? You have superior and inferior gluteal nerves. So gluteal maximus will be supplied by inferior gluteal nerve, but the medius, minimus and tensor fascia lata will be supplied by superior gluteal nerves. Okay, and you can find the action of the gluteus maximus is totally different from others. So it will do extension and lateral rotation of hip joint. Okay, so extension of hip joint means your standing position. Then your gluteus medius and minimus, they are important muscles when in your walking. Okay, and these muscles will be doing the abductor and medial rotator of hip joint. And what about the tensor fascia lata? So this is a very small muscle. This will help in gluteal maximus in the extension of knee joint. Okay, so you can remember the gluteus maximus and tensor fascia lata, they have the same insertion, okay, over the iliotibial tract, and they will do same action. Same action means extension of knee joint, means your standing position. Now because you know the gluteus maximus, as I already told you, it is the thickest muscle, largest muscle of the body. So this is the ideal for the intramuscular injection. Okay, and this is just to avoid injury to any special. Okay, now again next slides you will find that this, when you remove the gluteus maximus, you have many important structures inside, the muscles, the nerves and vessels. Okay, so avoid injury to these structures, the injection will be given on the upper outer quadrant of the buttock, means here in this area. Okay, you can divide the gluteal region into 4 parts. So upper outer quadrant, this site will be the site for the injection. Can you imagine which of the nerve will be there inside the gluteal muscles? Which now important nerve will be there which can get injured?
Nerve.
Very, very good. So we have many other structures, but sciatic nerve, which is very important and which is thick. So if you generally if you will give in the lower quadrant, you may injure the sciatic nerve. Another important thing about the abductors, as I told you, the abductors means the gluteus medius and minimus, which is supplied by superior gluteal nerves L5, S1 and S2. They are the very important muscles in walking. Okay, in your walking cycle, the first important muscles are the abductors, gluteus medius and minimus. So you have two pictures here. You can see this is the normal structure. So when you are walking, you can see your this left, okay, your left limb is above the ground. So when you are walking, what will happen? This gluteus medius will contract and it will keep the your pelvis bone or pelvic bone or pelvis in its normal position. Okay, so if you will just use this foot, opposite gluteus maximus will contract. Okay, if you use this leg, the opposite gluteus medius will contract and it will keep the pelvis in its position. Okay, so just you have to remember the opposite muscle is acting to keep the pelvic in position. Suppose there is injury to the superior gluteal nerve. So what will happen? So now you started walking. You took your foot off the ground. So this muscle, the opposite muscle, is not working. Okay? The opposite muscle is not working. So what will happen? This side, okay? This side will pull the pelvic of the other side, okay, and it will be raised. Okay, just maybe it is looking difficult, but it is easy. Okay, in the practical session you can try with the pelvis. So you have two gluteus medius which is keeping both the pelvic, means right and left pelvis, in position, right? So like this you can walk smoothly without any tilting of the pelvis. But if you have the paralysis of the right side, like in this case there is a paralysis of the right muscle, so your pelvic will be tilted to the left side. Okay, if there is a paralysis of the another side, means you have to remember only one line. If you don't understand also, just remember only one thing, that the pelvis will be sag, okay, or will be tilted on the contralateral side. Okay, contralateral means opposite side. So if the paralysis is right side, pelvic will be tilted to the left side, in simple words. And this sign, okay, if you see from behind that patient is walking and he has this problem, okay, this is called as Trendelenburg sign. Okay, this sign is called as Trendelenburg sign, and this gait is called as Trendelenburg gait. It will happen if the patient has only one-sided paralysis. Of only right side is paralyzed, you will find that the left pelvis will be, or left-sided pelvis will be dipping down. Okay, this is called as dipping gait or Trendelenburg gait. Okay, then suppose if the person both the nerves are not working, both the gluteus medius not working. So what will happen? It is called as waddling gait. Okay, so as soon as the patient will use the right leg, his right pelvis will be down. As soon as he will use the left leg, left pelvis will be down. Okay, just you can try on your pelvis. Okay, tomorrow you can try on the pelvis. You can find what is the or where will be the problem. Then we have the smaller muscles of the gluteal region. So as name already we know, piriformis. So piriformis you have already seen in the pelvic wall, okay, which will take origin from the sacrum. Then we have obturator internus. Do you remember the obturator foramen and membrane? So from the inner surface of this obturator membrane, you have obturator internus. Okay, then you have smaller muscles, gemellus superior and inferior, which comes from the ischium. Okay, and another muscle, quadratus femoris. Okay, so this also will come from the ischial tuberosity. So here again you can just revise. This is a picture where you have cut the gluteus maximus and medius, right? You can see the minimus. Below the minimus you have the piriformis muscle. Below the piriformis, you can see these three muscles together, in which you have superior gemellus. In between them, you have the obturator internus. Then below them, we have the gemellus inferior. Okay, so gemellus superior and inferior. In between them, you have the obturator internus. And just below this, we have the another muscle which is quadrate shape called as quadratus femoris. If you can see, you will find that all the insertions are coming towards the greater trochanter. Okay, so you can see the insertion of these all muscles are over the greater trochanter. What about the quadratus femoris? If you remember, in the first lecture we saw the intertrochanteric crest, and over the crest I told you there is a tubercle which is called as quadrate tubercle. So it will give insertion to the quadratus femoris. Okay, now all these muscles, they will be supplied by the sacral plexus. And all these muscles action, already told you, they are responsible for retrorotation of the hip joint. Okay, so this is the picture which is showing, as I told you, there are many important structures below the gluteus maximus. So these details are not required now, but we want you that you should know that this is the piriformis muscle, which is also known as key muscle. Why? Because above this, it is the gluteal, superior gluteal region, which has superior gluteal nerves and vessels. Below this, we have the inferior gluteal nerve and vessels, and very important, sciatic nerve. The sciatic nerve is coming out from the lower border of the piriformis. Okay, so generally for injection, this site is selected, which is free of any important vessels and nerves. Okay, so in gluteal region, you are supposed to study the gluteal muscles. Okay, then its nerve supply and its action and attachment. This is also very easy. If you will see one or two times, you can memorize easily. Now we have the thigh. So in the thigh, if you see, because of the intermuscular septum, the compartment of the thigh, it is divided into three compartments. Okay, so what are these three compartments? Anterior compartment, then we have posterior compartment, and then we have medial compartment. Okay, so muscles of the thigh, they are arranged in these three compartments. So first we will see the anterior compartment. So I hope that all of you remember that what is the nerve for anterior compartment? It is femoral nerve. Okay. So except the psoas major, we will see only one muscle which is not supplied by the femoral nerve. So first muscle we have the psoas major. Okay, so this is also not new. You have seen this in second year. Then we have the iliacus. Then we have the pectineus, this one. Okay, then you can see the largest muscle which is coming from the anterior superior iliac spine. Okay, then it is crossing our thigh and going towards the medial side. It is called as sartorius. Then we have the quadriceps femoris. Okay, quadriceps means it is a group of 4 muscles. Now you can see the psoas major and iliacus. It is together, it is called as iliopsoas. Iliopsoas. And it has the common action as well as common insertion. Okay, the origin is different, nerve supply is different, but its insertion and its action, it is similar. So what do you call it? Psoas, iliopsoas. What is the action? This will do flexion at the hip joint. Okay, if I will ask you which muscle is responsible for extension of hip joint, can you tell me?
Idiopathic.
Gluteus maximus, right. Now we have the sartorius. So it will take origin from the anterior superior iliac spine, and this is the largest muscle. You can see it is crossing the hip joint and also the knee joint, and it will be inserted over the medial surface of shaft of tibia. Okay, because it is crossing all the joints, so you can find its action will be also the flexion of the hip joint. Okay, then flexion and medial rotation of the knee joint. Okay, so now we are sitting on the chair. So what position we have acquired? Can you imagine? We have acquired the flexion of the hip as well as flexion of the knee. Are you agree with me, all of you? Okay, if you are sitting on the chair, your hip is flexed. Is it? Your knee is flexed. Right? Am I
Yes.
right? Yes. So this action is done by sartorius. So if you have problem, what is the action of the sartorius? So it is your sitting position. Then you have iliacus, which will come from the iliac fossa. Okay, and along with the psoas major, it will be inserted over the lesser trochanter of femur. Okay, this is also responsible for flexion. All the anterior compartment muscles will do flexion of the thigh. Then we have the pectineus. So pectineus is a muscle which is between the anterior and medial compartment. Okay, so it will come from the superior ramus of the pubis. Okay, where is the insertion? It is upper end of linea aspera. If you see in the figure, in some figures, they have mentioned as the pectineal line. It will also do the flexion and adduction of the thigh. Why it is adduction? As I told you, it is between the anterior and medial compartment. So it has additional action of adduction. Now we have the quadriceps. So what are the 4 muscles included in quadriceps? The first is the rectus femoris, okay, vastus lateralis, vastus medialis, and vastus intermedius. It means we have 3 vasti and 1 rectus femoris. So these 3 vasti, they will take origin from the shaft of the femur. Okay, but the rectus femoris, this is also a muscle which will come from the iliac bone, okay, and the acetabulum, from the anterior inferior iliac spine and acetabulum. So what is common about them is their insertion, okay, their nerve supply, okay, and as well as their action. Okay, so what is the common insertion? It is that all these four muscles, they form a common tendon known as quadriceps tendon, okay, which will go into the patella. Then from patella, it will form a ligamentum patelli, and final insertion is over the tubercle of tibia. What is the final insertion over the tubercle of tibia? Okay, if you remember, the patella is a sesamoid bone which develops in the tendon of quadriceps muscle. Okay, so the patella will develop in the tendon of the quadriceps muscle, and the final insertion of this ligamentum patelli will be over the tuberosity or tubercle of the tibia. Now, nerve supply is common femoral nerve, and all these muscles will do the extension of the leg at knee joint. Okay, so just all because these muscles are coming from the femur, they will act on the knee joint, and what they will do extension of the knee joint, except the rectus femoris has additional action because it is coming from the ilium bone, which will do flexion of the thigh at hip joint. So here again, what they want to tell you here, the tuberosity of tibia, do you remember? We saw there is anteriorly there is a tuberosity which will give insertion to the ligamentum patelli. Here again you can see all the four muscles, they are forming the quadriceps tendon. Okay, here we have the patella, and this is ligamentum patelli, which is finally inserted over the tibial tuberosity. Now we have something, the arrangement of the muscle in the anterior part of the thigh is like that. It will form a triangle. Okay, it will form a triangle. If you remember, you saw the axilla, boundaries of the axilla, cubital fossa. So like this, we have the in the anterior part of the thigh. Okay, the upper anterior part of the thigh, we have the femoral triangle because it has some important contents. So its lateral boundary, this is the lateral boundary which is formed by the sartorius muscle. Then it has a medial boundary which is formed by the adductor longus. The base is formed by inguinal ligament. The apex is formed by the meeting of the lateral and medial border. And the floor has four muscles. If you remember, just now we discussed, the first one is the iliacus, the second one is psoas major, because ilia and psoas, iliopsoas, they are together. Okay, the third muscle is the pectineus, the fourth muscle is the adductor longus. It will form the floor of the femoral triangle. The roof will be formed by the skin and fascia. So why it is important to know what are the structures present here? So here you can see we have the femoral nerve, okay, which is more lateral. Then we have femoral artery. Then we have the femoral vein. Okay. Now in this figure you can see that there is femoral sheath which is enclosing the artery and vein, but nerve is outside. Okay, always remember the femoral nerve is not in the sheath. In the sheath only you have the artery and vein. Okay, then you have here the deep inguinal lymph nodes. Now here, what is the clinical importance? Why you should know this? That in this femoral sheath, okay, this is the sheath of the fascia. If you remember, like carotid sheath, okay, we have here this femoral sheath which has artery, then vein, and the medial compartment of this is almost free. Here you can see it has only one lymph node. This is called as femoral canal. Okay, this is called as femoral canal. And this femoral canal, the upper part, it is called as femoral ring. And this is the site for the femoral hernia. Do you know what is hernia? Till now, have you studied any hernia?
Disc herniation.
No?
Just that kind of hernia.
Okay. So in maybe in more clinical, if you will go to the clinical side, you will find these cases like femoral hernia. So this is the site for the clinical femoral hernia, because this place is empty. Okay, so in female, this area, because of the wider pelvis, this area is very wide, so there are chances of herniation of the abdominal content here. So the patient will present to you with the swelling in the femoral triangle. Okay, so this, for anatomy purpose, only this much is required, but in the clinical side you may need to know more. Then as soon as you are at this point, okay, as soon as your femoral triangle will finish, okay, at this, after the apex, you will find the sartorius is continue. So if you remove the sartorius, you will find there are some important structures are present. Okay, but this is not a triangle, this is just a canal, so it is called as subsartorial canal, this area. Okay, if you will see, the sartorius has been removed. So this area below the sartorius muscle, you can see you have some artery, vein, and you have some nerve. Okay, so this is called as subsartorial canal. Okay, I cannot use the pen here, so I can show you that below the triangular canal, okay, below the triangular canal you have the canal. So this is the subsartorial canal or Hunter's canal. It is the tunnel in the middle third of the thigh. Okay, so anteriorly it has sartorius. Posteromedially it is the adductor longus and adductor magnus, and laterally you have vastus medialis, this muscle. Okay, so we have models. So we don't have these contents present, but the muscles are present. So you can try to find out the triangle and adductor canal. So what are the contents now? So you will see that the femoral nerve is not there because it is already divided into the triangle. So you have femoral artery, you have femoral vein, you have the lymph vessels, and you have some branches of the femoral nerve. What are these branches? Saphenous nerve and nerve to vastus medialis. Okay, next we have the medial compartment. Okay, so I hope you understood. Okay, so just before the lab, just try to give 10 to 15 minutes to read the slide and come, so you can see all the structures. So now we have the medial compartment. So you can see the medial compartments, the muscles, they are coming mostly from the pubic bone, maybe from the body, from the ramus. Okay, and they will be inserted over the femur. So what are these muscles? Brachialis and three adductors, adductor longus, magnus, brevis, and then obturator externus. So obturator externus is easy, we all know it comes from the obturator membrane, outer surface of the obturator membrane. So they all will be supplied by obturator nerve. So what is the nerve of the medial compartment of thigh? Obturator nerve. Okay, so here again you can see all the muscles together. Okay, then you can see the opening in the adductor compartment, in the adductor magnus muscle. If you remember, in femoral artery we saw that it will pass through the hiatus of the adductor magnus muscle. So this is the area from where the femoral artery will pass. This is obturator externus, which is coming from the external surface of the obturator membrane. Okay, so for origin, just I will tell you in short that all these muscles will be coming from the pubic bone. Okay, the adductor magnus, at this is the large muscle, magnus. Magnus means the bigger one. The longus means the longer one. brevis is short. So adductor magnus has two origins. One is from the ischial tuberosity and another is from the pubic bone. Okay, in which the gracialis will be inserted over the tibia, the longus, brevis and magnus, they are all inserted over the posterior surface of femur. And obturator externus or the medial surface of greater trochanter. What is the nerve supply? All these muscles will be supplied by obturator nerve. So medial compartment will be supplied by obturator nerve. But can you see any difference here about the adductor magnus? That it has two origins. One is from the pubic bone, another is from the ischial tuberosity. Okay, and it has two nerve supply also. So so it means the adductor magnus has two parts. The one it is called as adductor part, which is supplied by obturator nerve. The another is the hamstring part, which is supplied by sciatic nerve. Okay, now what is hamstring? We will see in next slide. So the muscles of the posterior compartment, they are called as hamstring group of muscles. Okay, muscles of the posterior compartment, they are called as hamstring group of muscles. So what are the muscles included in the hamstring group? So first of all, we have the semitendinosus, then semimembranous. Semi means it is like semi-tendon, semi-membrane. Then another, it is the hamstring part of adductor magnus. So as I told you, adductor magnus has two parts. One which is in the medial compartment, which is supplied by obturator nerve. The another part which takes origin from the ischial tuberosity, it is called as hamstring part. Okay, so 1, 2, 3. What is the fourth muscle? Is the biceps femoris. So again, this is very easy to remember. All these muscles will take origin from the ischial tuberosity. Okay, all these muscles will take origin from the ischial tuberosity, and because this is the posterior group, so most of the muscles you will find it will come to the linea aspera. So here you can see that origin is from the ischial tuberosity, ischial tuberosity, ischial tuberosity. Okay, so it will be inserted all over the medial condyle of tibia, adductor tubercle. So this I will tell you in detail. So first, what is the another thing which is important is about the biceps femoris. Do you remember the biceps of the upper limb having two heads? Like this, we have the biceps femoris. In the lower limb, it also has two heads, short head and long head, in which the long head takes origin from the ischial tuberosity. Short head takes origin from the linea aspera. Okay, and lateral supracondylar ridge of the shaft of femur, means it is coming from the lower down. Okay, and the long head, it is coming from the above. So what is the insertion? The both of this head will form a belly, and after that it will be inserted over the head of fibula. Okay, again here you have to remember that the long head is supplied by sciatic nerve. The short head is supplied by common peroneal nerve. What is the action? So just remember the posterior muscles, the hamstring group of muscles, they are responsible for the flexion of the knee joint. So they will do flexion and lateral rotation of the knee joint. Okay, in which you will see that semimembranosus and semitendinosus has same action. They will do flexion and medial rotation. Okay, So what about its nerve supply? The nerve supply of these muscles, if you remember, the sciatic nerve, it divides into two parts, tibial and common peroneal. So these muscles are supplied by tibial part of sciatic nerve, except the short head of the biceps, which is supplied by common peroneal nerve. Okay, what about the insertion? So biceps, it will form a tendon inserted over the head of the fibula. Then you have semitendinosus, it will go till tibia. Semimembranosus, this also will go till tibia. Okay, what about the adductor magnus? Okay, the adductor magnus will be inserted over the adductor tubercle of the femur. I hope all of you remember the adductor tubercle. Okay, so just tomorrow try to find out all these landmarks and its important attachments. Okay, so this slide, just the same thing. Here we want to tell you what is the nerve supply action in short. Okay, so here we finish. Inshallah, tomorrow we will see all the muscles, right? So what is the nerve for the posterior compartment of thigh? Can anyone tell me before finishing?
Hamstrings muscles.
Hamstring, very good. These are called as hamstring muscles. What is the nerve supply for this? This is supplied. Very good. Very good. Tibial part of the sciatic nerve, except one. Except what? Here we have mentioned, except the short head of the biceps, which is supplied by common peroneal nerve. Okay, so you have to remember the sciatic will have two divisions, tibial and common peroneal. Okay, so we will finish here. So maybe I went very quickly because of to finish on the time. So anything inshallah we can see in the practical, but I will advise you just give 10 to 15 minutes before the lab so that you can prepare yourself. Just see, go through the slide before coming to the lab. Is it okay? Any questions? Okay.
Thank you very much.
Thank you so much. So I will finish here. Good luck. Have a nice day.